Thanks again, the organizing committee, Manos and Manos, for this superior Congress. It's excellent, your work and your effort. Now 10 years right now. It's excellent what you're doing and your work. So let's start, and also I would like to thank Zimmer Biomet for the invitation to present our technique using the superior capsular reconstruction with all biologic biceps tendon. Let's start with a patient. We have a female patient, 54 years old, no trauma. 2 years he had symptoms. He made an overhead activity. This is her clinical evaluation. And if we go to the MRI, we'll see that it's like this. So a very difficult problem, a massive rotator cuff tear in a very young patient, active patient. She makes agricultural works and fat infiltration of the supraspinatus of grade 3. Before some years, I would try to make a study regarding these massive tears and the repair of them. And we found, when I was resident, about 50% of re-tear rate and about 40% of re-tear rate where I've made my fellowship. So it's the same thing. Massive rotator cuff tears remains a great problem. So we thought about, with Johan Barr from Grenoble, can we change this natural history and can we make something for these massive tears? Mihata described this excellent idea using superior capsular reconstruction with the fascia lata, and this is very great idea. However, sometimes it is technically demanding. He uses only fascia lata, but it can be technically demanding for somebody. From the American part, we have introduced using not the fascia lata, but use an allograft or an autograft and make it more easy and a prepared graft and no donor-site morbidity. However, it remains expensive. We've heard a lot today about the costs. And also some grafts, some studies show that they have 62 graft failures of these xenografts, allografts, or prepared grafts used for superior capsular reconstruction. So in 2017, we had the idea to use the biceps tendon for superior capsular reconstruction. And this is the technique right now that we're using with all suture anchors to minimize also the cost. I think sometimes the all suture anchors can be cheaper, and also to minimize the hardware that we're putting in the patient. So we prepare the humerus and you use the biceps. We put the sutures through the long head of the biceps, and we make lasso loop configuration. Then we cut the long head of the biceps and we transfer it onto the greater tuberosity. Where is the supraspinatus? We see it can cover all the greater tuberosity sometimes. In many of the cases with patients with massive rotator cuff tears, the biceps is already hypertrophied. So it can cover it's a very good graft, and it can cover all the humeral head sometimes. We don't cut these sutures, but we pass it through the supraspinatus, the retracted supraspinatus, and we tie it without any traction. Also, we use side-to-side configuration with the infraspinatus, and the infraspinatus with a suture anchor, with a different suture anchor, and all suture anchor, like the juggernaut here, we can fix it onto the greater tuberosity alone. However, the same sutures we also pass it through the long head of the biceps. And this is the construct subacromially. It's not very technically demanding. And this is from the subacromial space. And you see from the intra-articular, it's like to have a supraspinatus fixed. So, it's not, this is a video. Normally it plays. In this video, we're showing that the biceps also prevent superior migration. It can act as a path augmentation, it can act as a superior capsular reconstruction, or it can act as a tenodesis effect. We don't know exactly, but the final role that gives us a superior capsular reconstruction for us, and also for biologic augmentation, we think it's very important. So I remember right now in 2017 I was in Thessaloniki. It was our National Society Arthroscopy Congress, and it was the first time that I will try to present this case. Everybody was a little bit skepticism about it. Is it painful? Is it not painful? Why use the biceps? We cut the biceps many years right now. And from 2017, we have many authors that they reported several techniques using the biceps for superior capsular reconstruction and for augmentation. And we have 4 editorials about it. And also we have 4 biomechanical studies shows that really the biceps, it works. So can we control the tear and can we control the extension of the tear over time? We published this in 2021 and we make a study comparing 3 different techniques. The classic double row, the use of a patch with a transosseous equivalent technique, and also the biceps. And we found post-operatively, 2 years post-operatively, that we have better strength using only the biceps. We found that with the other 2 techniques, the re-tears rates remain the same, about 40%. Using the biceps, we had only 1 case of re-tear of the supraspinatus, and it's probably a valsion of the biceps tendon. But we had no re-tear of the infraspinatus. So this is very important. We have subscap intact, infraspinatus intact, and this is probably the most important for keeping the function of the shoulder. So the muscle couple force are preserved. So in these cases, even in the re-tear of the supraspinatus, even the re-tear of the biceps tendon, the strength was better in this patient than with patients with re-tear using a double row technique or a patch. So as here of the biceps, have we extended our indications today? It's only for these massive tears. Let's go for 1 case. So this is our extreme case. It's a male 52 years old, heavy worker, that he has a trauma of his left shoulder. This is his clinical examination. But if we go to his MRI, we see rupture of the musculotendinous junction. Very difficult cases. So in this case, you see the arthroscopy. We have a very good tendon attached to the greater tuberosity, and we have slap lesion, and also we have a musculotendinous rupture. In this case, I repair the slap using an old suture anchor. This is a Jaguar 2.9. So I fix the biceps very well under the glenoids. And then a triple-loaded old suture anchor again. The sutures are passed through the biceps. I'm seeing what is the best tension. This is the most sometimes subjective, which is the best tension to give to the biceps during this technique. And I think it's sometimes subjective, and it depends from the experience. And all the sutures that are passed through the biceps right now are passed through both the tendinous and both the muscle tendinous parts of the rupture. So this is the final image. And we can see 1 year post-operatively in a patient that was almost pseudo-paralytic. And this is his, normally this is a video. His MRI that he sees that we have a heel tendon. Case 2, a female patient, 69 years old, early stage of dementia, 7 dislocation, and of her right shoulder in a 2-month period. This is her clinical examination. She's very good, but the shoulder is really unstable and has no power. She can do her daily activities. She has dementia. Probably some could say that we can do a reverse. This is her clinical examination. She has dislocation even during dressing. This is her MRI. We have an intact subscap. We have a massive rotator cuff tear. And she's unstable. This is her bone loss on the humeral side, no bone loss at the glenoid side. So in this case, we combine superior capsular reconstruction. It's with a 3-YA procedure using an arthroscopy. The 3-YA was made to heal the instability, the anterior instability. So using a button, we bend only the coracoid. We put a graft to fix also the bone loss that he had, that the humeral had, and to cover a little bit, not 100%. using a nodes technique. And then finally, to repair the massive rotator cuff tear, we use the biceps for a superior capsular reconstruction with only one suture at a single row technique at the medial side. And this is 1 year post-operatively. So where we are now with the ACR, I took this photograph from ESCA from the recent Congress, and they say that one technique started, we have an open mind and we start one technique. And we start to promote this technique, and we have, the technique will be over the months or over the years, over-rejected, over-appreciated a little bit, and be in the intermediate level, or adopted finally. And we're very, very happy that starts to be adopted worldwide. So in conclusion, the superior capsular reconstruction with the biceps remains a very safe procedure with no donor site morbidity. We use a local tissue autograft if the bicep is present. We don't use any allograft. Also, we preserve the vascularization probably from the glenoid anchor, and we have no risk of injury of the scapular nerve. We don't use any other materials. It could be someone that's cost effective. However, we need longer follow-up. Why not? It doesn't burn any bridges. So over the decades from the patellar tendon ACL reconstruction, we moved to the hamstrings. Why not to use right now the biceps for the rotator cuff? It could be the autograph of the decade. Thank you a lot.